PAO as we go forward. So the evolution of PAO, there has been, I began in the 1980s, 1987, 3 years after it was started in Bern. And initially we had exposure, the external aspect of the innominate bone. And that kind of went away, and we've started doing everything from the inside of the innominate bone. One of the things we did at the beginning always was cutting the ischium from the quadrilateral surface outward. But I've kind of abandoned this, as usually the initial cut that we make just going around the inferior hip capsule is adequate for the ischium. The rectus femoris, this was always taken off at the beginning of PAO. I began leaving it on, and I think I learned from anterior total hip how much you could see the joint still leaving the rectus in place. So as it was my impression, I was the first one to start talking about leaving the rectus on. But later on, in later years, I was surprised that many surgeons who preserve the rectus origin make the ischial cut passing the osteotome medial to the rectus. As we left the rectus on, it was always my technical approach to pass the osteotome lateral to the rectus femoris, which I think is better. Now, a retroversion, I don't know, some of the other experts should comment here, but when I see a lot of PAOs, let's say, done elsewhere by people that aren't of the status as some of the people on the panel here, I see a lot of retroversion. I see problems with lateralization, I see problems with retroversion, and it just makes me think that one of the problems, I think the big problem is the ischial cut. People don't get the ischial cut right. They do an ischial cut that causes a hinging, so they hinge the acetabulum on the ischial cut rather than getting a translation at the level of the ischium. So they really have kind of an incomplete ischial cut. It often goes too distal, and then they end up retroverting the acetabulum, sometimes lateralizing the center of rotation. So with the ischial cut, I'm just going to talk about, I think one thing is to get the correct angle for the ischial cut. It's better to go lateral to the rectus around the inferior hip capsule than medial to the rectus. So with the PAO correction, just to go back to the basics, the center of rotation of the hip is going to move a little bit distal, and it's going to move a little bit medial with a true dysplastic hip. And in order for this to happen, the distal acetabulum has to move medial. So there has to be a translation, not just a hinging at the ischial cut. So here's a pre and post-op of a dysplastic acetabulum, and you can see that the little arrow on the left is showing the way the center of rotation moves, and you can see how Shenton's line gets restored. And also there's a medialization of the center of rotation, so we're making a more normal hip. And the reason the head goes distal is because we have the horizontal, the transverse plane cut through the ilium, so as you rotate it, that corner of the medial portion of the acetabular segment, it actually creates a distraction at the ischial cut, so it's moving a little bit distal. One other thing I was just going to point out, it's not subject to the talk, but you see there's a fatigue fracture of the rim. So this portion of the rim broke off because of overload. It took the labrum with it. There was no fixation of this fragment, but at follow-up views, the fragment healed. So it kind of begs the question, if a fragment that's been sitting loose, a non-union for a year, can heal back with any fixation, can't a labrum heal back once you change the loading in the joint? And it'd be an interesting thing to look at, and it may be why the results are, many cases, just the same, whether you do a labral suturing combined with a PAO or you don't do anything. Now, if you look at the this is just an article, Techniques in Orthopedics, where I go through my technique for PAO, if anybody wants to look at it. If you look at the original technique from Gans, you look, let's see here. I'll go forward. Do we have a pointer on here? There's no pointer, I guess. Okay. So anyway, if you look at the lower left one, you see that this is the original article from Gantz, how the osteotome is going into this flat surface, the anterolateral surface of the ischium is where it's going. And then this is a cut from on the right side from the inside of the pelvis that I do once in a while if I'm having trouble, but not so much. I did it initially in all cases. Now, the potential cut medial to the rectus, just what I think may happen is that if you're going medial to the rectus, this concave osteotome ends up on this sharp surface of the medial ischium. And then the direction, if it's going directed to distal, it can go into the ischium in a direction distal to the superior pole of the ischial tuberosity. So when it goes in that direction, you're not going to be able to translate the ischial cut. It's just going to hinge on the ischial cut. So just like we looked on the last slide, the cut needs to be a little more proximal to the superior pole of the ischial tuberosity, and the cut needs to be close to the acetabulum. So you this on a plastic bone model, but I'd also say the pubic cut is best made very close to the acetabulum. This is where the thick bone is, and then it's closer to the center of rotation, so it doesn't translate as much, and there's more chance of union by making both these cuts close to the acetabulum. So this is a 32-year-old female. She had a PAO, and afterwards she reported, she said her hip gave out. She had continued pain or symptoms. She had more pain afterwards than before. This is the x-ray she has. This is a retroversion. So I think you can see that concave line through the head. That's superimposed on the head. That's the image of the posterior wall. And reading the op report, the surgeon said, well, I made the cut of the ischium 10 millimeters distal to the acetabulum where I normally do, and you can kind of see the whole cut, but it's actually going a little bit distal to the superior pole of the ischial tuberosity. So what did he get? He retroverted this, and sometimes you'll see this picture. You see where just proximal to the joint, how the inferior spine, that segment of bone is very lateral and prominent. This is just a mistake I see again and again as a retroversion. So this was a redo of it, and so you can see the posterior wall coverage is markedly increased. It's a redo. Maybe I have a little less anterior coverage than would be ideal. It's pretty comparable to the other side, but I think it's pretty good for a redo of PAO, and she is very happy with the result at this time. It's an early result, just a few months out, but we certainly corrected the acetabular retroversion. Now I'm going to just show a video here. There's some sound with it. I'll just let the sound play. No sound, huh? They said there was going to be sound. Sliding proximal, the tip is sliding proximal as I refer to the tip is against the interior ring of the acetabulum. Okay, we bring the answer. The tip of the osteotome where the medial center, just drop my hand a little bit. Okay, take one straight. Okay, so right now I'm at the edge of the optic femur, and I'm going to So we need to get the femoral neck out of the way to get more lateral on the ischium. Abduct the hip. So anyway, just to get the ischial cuts so it'll translate, the goal is to me that we need to be in this subastabular groove, this very hard bone. Getting it too distal is not good, and the osteotome needs to be heading somewhat in a lateral to medial direction, which to me is quite hard to do if you're putting the osteotome medial. Way to do it, but completing the ischial cut allows the translation, going to prevent the retroversion and lateralization. Thank you.
Recording in progress.